So welcome everyone to Let's Code Together, this month's webinar. My name's Jane Knight and I'm also joined by Dr. Carol-Ann Wilson. Together we'll take you through this session for the next 90 minutes.
Hello everyone.
Welcome back if you're familiar with these sessions, and if you're new to these Let's Code Together webinars, we're very pleased to have you join us. So the first slide explains that MEDRA came about in the mid-1990s. It was an ICH initiative to develop the terminology. At the time, the MSSO, whom we both work for, was put in place to maintain and distribute MEDRA. The activities of the MSSO are overseen by a management committee with representatives from both the industry and the regulatory authorities, some of whom are listed on your screen. The next slide explains that MEDRA is owned by ICH, as is the material that we're going to share with you today. You can't quote the material without acknowledging ICH, and if you change anything, then you can't assume that you have agreement to do so. We don't share the slides from these webinars, just in case you're wondering. We do share the recording, but because the real value of the session is in the discussions, we only share the recording. We want the session to be interactive, so audience participation is very important to us, and we encourage you to use the questions panel in the GoToWebinar to ask questions or comment. Sometimes we may not all agree on how the examples should be coded, and in the interest of time we may have to agree to disagree. We can't, unfortunately, take requests to code your individual verbatim terms today through the questions, but at the end there will be an option for you to propose examples or general topics for us to consider to include in future sessions. But please make sure that these are of in general interest to the wider audience. And you'll notice that some of these, in fact, most of these examples that we've received today have come from suggestions at the end of the previous webinars. So I mentioned already we're going to be using Poll Everywhere so that you can express how you would choose to code the terms, and you can join this. The easiest way is by scanning the QR code with your mobile phone, but if you want to do it on a computer browser, you can do this by opening a browser like Edge or Internet Explorer, Chrome, whatever you prefer, and just typing as the URL pollev.com, nothing else, just pollev.com. When you get the screen that you see on the right hand side, you enter my name as Jane Knight 855. That's the username. The polling is completely anonymous. There's no need to enter your own name, and then you can click join. If you get stuck along the way, just send us a quick message that you want to see the QR code and we'll share it with you again. So the first one, to test the polling, where are you joining us from today? Oh, someone's in the middle of the ocean. It's very small, I know, on your, North America, welcome. Canada, United States, South Africa, welcome. Looks like New Zealand, India, lots of you in Europe. It's hard to distinguish there. Any more, Carol-Ann?
I see Turkey. Yeah, it's difficult in Europe. Italy, Spain, buenos días, buongiorno.
Welcome.
Maya Batu, Turkey. Yeah, so a lot of people. Maybe Georgia. I don't know. It's hard to. China is there.
I know. Welcome. I always find this such a privilege when I see it. I know I've said that before. It's lovely to have you all with us. So I mentioned we're going to be sharing the web-based browser. If you don't have your own credentials to hand and you wish to use the browser, you can use this temporary demo password. It will only be available for 1 week until Friday of this week. So there's a new demo password every week. So if you don't have to use it, you can just watch the slides, or you can use your own credentials if you prefer. Coding, very often there's not an exact match, and this is why we do these sessions. Sometimes, as you'll see, there's more than one possible way to code a verbatim term. And even the Points to Consider document offers options in places where there may be several approaches. Sometimes it's a case that when we read a term, we understand the term differently. So when we do code, what we say is that we code by making the best approximation and selecting the best LLT we can. But overall, we must always code as reported. That's what you'll see today. No assumptions at all. And we always include a picture like this. We say perception. When you first see a verbatim term, very often your brain wants to make sense of it. It's very common to try and make assumptions or to perceive things about the verbatim. And you see here with this graphic, our brain wants to see is the context of the two red circles, the larger yellow circles compared to the smaller yellow circles, makes our brain see the two red or orange circles differently. And I think you'll probably agree with me, the one on the right looks to be so much larger. Similarly here, we see again the importance of context, that these two orange lines, when displayed against what looks like a railroad or a ladder, they become the top one seems to be much larger when actually they're exactly the same size. So it's the same with verbatim terms, and sometimes the context can make us perceive or see a term in a different way. So something to be aware of when we look at today's examples. Overall, though, it's a balance between coding rules that give us consistency and medical judgment that means together we can then manage the risks to patients. Medical references are helpful, and we'll see that today very clearly, the importance of referencing events. Sometimes you might find there isn't a term available in MedDRA to adequately represent the concept, and you decide to request that a new term can be added to MedDRA. So having said all of that, I'm going to switch my camera off so that we can all focus, and let's code together.
So let me show my screen now, share it. And so we will start the session with 4 examples we couldn't cover in our session in May. And our first verbatim describes a collapse due to low blood pressure. So is it clear what happened to the patient, what is described by the verbatim? And can we find an appropriate combination term, perhaps, for this condition, or is split coding required? And what would be the appropriate LLT or LLTs? Now, how would you approach this verbatim? Which of these LLTs would you assign, or would you split code? Collapsed, circulatory collapse. So collapse seemed to be a very good option because it's exactly matching what has been reported, at least part of our verbatim. Circulatory collapse would be an option. Blood pressure low, syncope, hypotensive, or hypotensive crisis. What would be your choice here? See you voting. And now let's look what you're going for. So most of you would code to blood pressure low, and circulatory collapse is an option, syncope, hypotensive, and collapse. So there's a split of opinions. Most of you would, of course, consider the blood pressure low. Others would code to syncope, hypotensive, but nearly the same percentage would also go for circulatory collapse. Yeah, obviously it seems to be an easy term, but it's not as easy as it is at first sight. Let me close the poll and try to clarify the medical background a bit. So let us first look into the Dorlins. Collapse is described as a state of extreme prostration and depression with a failure of the circulatory system, meaning a state of extreme mental or physical exhaustion and mental or physical depression. But other sources, like the Merriam-Webster dictionary, describe collapse as to fall down, helpless or unconscious. And the Cambridge dictionary explains that if somebody collapses, they fall down because of being sick or weak. So in everyday speech, collapse or collapsed means different things. The term shock is often used synonymously with circulatory collapse and is defined as a condition of profound hemodynamic and metabolic disturbance, characterized by a failure of the circulatory system to maintain adequate perfusion of vital organs. So very serious condition. It may result from inadequate blood volume, then we talk about an hypovolemic shock, inadequate cardiac function, then we would talk about a cardiogenic shock, or inadequate vasomotor tone, so a neurogenic shock or a septic shock. And the medical term syncope refers to a temporary, transient suspension of consciousness due to generalized cerebral ischemia, and it is also called faint. On the website of the Mayo Clinic, we can find a description of the symptoms of low blood pressure, because our verbatim describes a condition in the patient due to low blood pressure. And the symptoms that are listed here are blurred or fading vision, dizziness or lightheadedness, fainting, fatigue, trouble concentrating, and nausea. And we are told that a change from just 20 millimeters of mercury, like a drop of systolic pressure from 110 to 90 millimeters of mercury, can already cause dizziness and fainting, and an extremely low blood pressure due to, for example, uncontrolled bleeding, sepsis, or an anaphylactic reaction can, of course, be life-threatening and lead to shock. Here, just for your reference, the paragraphs in the chapter of the MEDRA introductory guide that are relevant for our verbatim. You can see that high and low terms in MEDRA are generally considered to be lab values, so investigational type of terms, and are found in SOC investigations. But there are exceptions to this rule, and one of them is the LLT blood pressure high and the LLT low blood pressure. These are linked to the PT's hypertension or hypotension and are grouped in vascular disorders. So they are not considered investigational results. And the same holds true for certain temperature concepts like high temperature or spiking temperature. These are also not grouped in SOC investigations, but in SOC general disorders and administration site condition. Although there are, of course, investigational results, they are most frequently used as an expression for fever, and that's why they are grouped as they are. These are the exceptions, always important to remember. Now let's have a look at the terms that we proposed in the Paul and Browse MEDRA. Here we are, and let's look for collapse. So I've activated the show non-current LLTs, and if I look for collapse and search, I will find an LLT collapse, but it's definitely marked as non-current. If you see, look at the legends, you see that red lettering and the red circle around an LLT indicates a non-current term. So if I do a right mouse click and go to the browser, we can see that this term is grouped under circulatory collapse. Also, the collapsed LLT that was visible in our poll is non-current, and circulatory collapse is grouped under HLT, circulatory collapse and shock. So quite severe conditions here, anaphylactic shock, cardiogenic shock. So these conditions represent really serious conditions in the patients that, as you saw in the Dorlands, mean that the blood circulation is impeding adequate nutrition of vital organs. So this was one of the options, collapsed. Obviously, we cannot assign this LLT because it's non-current, so it's not an option. And the same holds true for circulatory collapse, because it's a very serious condition, and this is not reported in our verbatim. But so the other option was hypotensive crisis. Let's see if it's listed here. Hypoperfusion, no. Let us look for hypotensive crisis. Where do we find this? Here in search. Go to browser again. So it's grouped under SOC vascular and under vascular hypotensive disorders, without any further LLTs underneath that would better indicate what is meant by this term. But when interpreting this term in the same way as the opposite condition, that is hypertensive crisis, a hypotensive crisis refers to a sudden severe decrease in blood pressure, representing a medical emergency. So this is, again, not what was reported in our verbatim. Blood pressure low, just to show you, many of you will already be familiar with this, is an LLT, of course. Here it is. Go to browser, and you see it's grouped under hypotension. So this is one of the very few investigational findings which are linked to a PT representing a diagnosis that I've shown before. And now the last option that we had in our poll was syncope hypotensive. Here we are, syncope hypotensive. Go to browser in order to see where it's grouped under: disturbances in consciousness, cardiac signs and symptoms, circulatory collapse and shock as well. So it's also considered, whoops, here we are, grouped under neurological disorders. No, didn't manage. Here we are, syncope. So we have quite a number of LLTs underneath this PT here: cardiovascular syncope, cardiac syncope, fainting, orthostatic syncope, exertional syncope, postural. So we saw in Dorlands that syncope refers to a temporary transient suspension of consciousness due to generalized cerebral ischemia. And this could be caused by low blood pressure. If somebody feels dizzy or suffers from pre-syncope, this is what you usually do. You let the person lay down and raise the legs so that cerebral blood flow is improved. So this seems to be the best choice. It covers the etiology, the low blood pressure, and that the patient collapsed or fell down due to temporary cerebral ischemia. Let me go back to my slides. Here we are. So when looking at such a term, you would always look out for a combination term that would capture the full reported information. One would also refer to reliable medical references to first get a clear understanding of the reported condition and to distinguish the reported condition from similar terms. And when not finding a direct match, apply medical judgment. Use replace words, quasi-synonyms, and also medical terms in order to find a suitable term for such a reported condition. But because the term collapse and collapsed are ambiguous, first try to clarify the background for the ambiguous term collapsed, because it could relate to a serious condition, for instance, due to severe blood loss, and rather represent a circulatory shock. But if no clarification can be obtained, we propose to code the verbatim to LLT syncope hypotensive under PT syncope, because the wording is rather layman's, so that this event was rather not reported by a healthcare professional. And in lay language, it would rather describe a fall or fainting. And this is what you have also suggested, most of you at least. So did we receive questions?
No
Jane?
questions. No, Caroline, no questions so far. Maybe it's just sinking in with everyone.
Okay, so then let's continue with the next one. Here we have a bacterial peritonitis with a positive culture for alpha-hemolysing streptococcus. So is this reported condition clear and unambiguous? Is it one medical concept, or is split coding required? And what would be the most appropriate LLT, or what would be the most appropriate LLTs when considering split coding? Again, how would you approach this verbatim? Would you select LLT peritonitis, infectious peritonitis, peritonitis bacterial, alpha-hemolytic streptococcal infection, or alpha-hemolytic streptococcus test positive? What would you do? Would you split code? Would you just select one of these LLTs? What would you do? So let's see again what you are going for. So most of you are voting for peritonitis bacterial and alpha-hemolytic streptococcus test positive. Some of you also would consider alpha-hemolytic streptococcal infection or infectious peritonitis. Let me close the poll and first refer to the Medra-Term selection points to consider document in order to get some guidance. So this document now provides guidance for similar scenarios. If a verbatim includes both the information about a specific microorganism and the affected body site, and no Medra combination term is available, the preferred option is to select terms for both the microorganism infection plus the anatomic location of the infection. And here's an example. Klebsiella kidney infection would be coded to Klebsiella infection plus kidney infection in order to capture both the microorganism specific infection and the anatomic location. Alternatively, you could also prioritize the information and only code the infection of the specific body site or the microorganism specific infection, meaning that you could either select LLT kidney infection or the LLT Klebsiella infection. So this is one of the scenarios where the points to consider document provides different options for coding approaches. So in our trainings, we always follow the preferred options mentioned in the PTC guidance. Now, our patient suffered a bacterial peritonitis and in addition, a positive culture for streptococcus alpha-hemolysing was reported, not an infection by the streptococcus. This investigational finding may not at all be related to the diagnosis bacterial peritonitis. It is not a positive culture of the peritoneal fluid that is reported. The culture could relate to blood, an abscess, endocarditis, cerebrospinal fluid, etc. And another section of the PTC guidance for Medra-Term selection is also not helpful for coding our verbatim because it does not fully match our verbatim. In the PTC document, we are told that when investigation results are reported with a diagnosis, we should select only one term for the diagnosis if the investigation result is consistent with the diagnosis. And the example is obvious. If an elevated potassium level is reported together with a diagnosis hyperkalemia, we would only code the diagnosis. But as mentioned earlier, our investigational result is not fully consistent with the diagnosis bacterial peritonitis. The positive culture finding could relate to other body fluids as well, not only to peritoneal fluid. Alpha-hemolysing streptococcus is a bacterium, yes, but the information provided in the verbatim could relate to really two different medical conditions. We don't know. So let's switch to the browser to find a suitable term or terms again. So let's look for peritonitis. Here we are. Here we have a very vague term, and it's also grouped under infections pathogen unspecified. Here we know that it was a bacterial infection. So we would, another option was infectious. Of course, we have a general term for an infectious peritonitis. Here it is. It's also grouped under infections pathogen unspecified. And now what about the bacterial one? Here we are. If we look at the hierarchy now, we see that again it's primary SOC, it's infections and infestations, of course, but this PT is grouped under HLGT, bacterial infectious disorders. So, but this would be the most specific term that we can find, because there is no term that would cover the streptococcus information. So we would have to generalize this information and assign peritonitis bacterial. What about the alpha-hemolytic information? Here we are. We have an alpha-hemolytic streptococcal infection, but the only thing that we have in our verbatim is that there was a positive culture result for alpha-hemolytic streptococcus test positive. So we should not assume that this is already representing an infection. And therefore, the alpha-hemolytic streptococcus test positive LLT would be the best option for us. And it's grouped under PT streptococcus test positive. So let me go back and to my slides and continue with the learning points. So if you get such more complex verbatims representing multiple medical concepts, always refer to the MedRA term selection points to consider document if no suitable MedRA combination term is available, and look out for guidance how to handle such verbatims or how to prioritize the information received. Always code as reported, the principal MedRA coding rule. Do not add or subtract information, but try to capture all information received as really specifically as possible. So in this case, do not assume that the positive alpha-hemolysing streptococcus culture relates to the reported bacterial peritonitis. It could be that our patient developed a sepsis, for instance, due to the peritonitis, so a complication of the peritonitis, and this would have to be coded separately. Do not code to an infection term if only an investigational result for a specific infectious agent is reported. So with this, Our suggestion would be to code to LLT-PT peritonitis bacterial and to the LLT alpha-hemolytic streptococcus test positive under PT streptococcus test positive. Any questions, Jane?
Yes, we do have a question. We have a comment that because peritonitis bacterial maps to the SOC of infections, and the second PT, the comment you made that you've just explained, it's better to code it to code as reported. It's a test, streptococcus test positive, because the comment that came in just before you said that was, wouldn't it be better to code to the streptococcal infection rather than a test?
Yeah, but we really don't know the exact background of this verbatim. As I said, it could be that it is a bacterial peritonitis that is reported, and we have a term for that. And the positive culture of the streptococcus alpha-hemolysing could relate to a completely different condition, could be an abscess whatsoever in the patient. So we should not assume that the bacterial peritonitis was due to the alpha-hemolysing streptococcus, and that this positive culture was made out of peritoneal fluid. It's not reported as such. So it could really relate to two separate events, separate findings in the patient, even a complication of the bacterial peritonitis. So in order to capture all this information, we should really split code in this instance. We are on the safe side then. We have captured the full information. We have not made any assumptions about any causal relationship between these different diagnoses and investigational finding. So with this, we are really on the safe side. We are not interpreting anything. We are not adding information, but we are also not omitting any information. Any further questions?
Comment just is that, as you say, the culture test is sensitive to contamination, so it's going for the test result is less interpretive, and that's very good. And then there's a comment, but I think there's a comment saying that if we don't know the result, we shouldn't code it as a reaction. No, if we have a result, terms with quantifiers should not be coded as a reaction. Therefore, I would not code strep test positive. I'm not exactly sure on that comment, so I don't know if you.
No.
I think it's what you've just explained, Carol Ann, that we don't assume a diagnosis from a test result, and that's all
we
the
have
comments
information
so far.
that we have the information that there was a positive culture for streptococcus alpha-hemolysing. So that's why I would capture this information, because otherwise we may omit relevant information because the patient may have, this may relate to a completely separate condition in the patient.
That's all, Carol Ann, so please carry on. Thank you.
Next one is quite complicated. So we have a DLBCL relapse with CNS involvement. What could this relate to? And is the abbreviation DLBCL unambiguous? CNS stands for Central Nervous System, and you'll find several terms in MedRA that include the abbreviation CNS. So this abbreviation is obviously unambiguous. But what about the abbreviation DLBCL? Could this verbatim be a confirmed diagnosis with added related clinical signs and symptoms? And how to best code this? Is split coding necessary? DLBCL relapse with CNS involvement. So how would you approach the DLBCL relapse with CNS involvement? Would you code to diffuse large B-cell lymphoma, diffuse large B-cell lymphoma recurrent, central nervous system lymphoma, primary central nervous system lymphoma, metastatic lymphoma, or would you seek clarification? What would you do? quite a complex verbatim, but we are often asked to really also address verbatims in the area of oncology. So I see you voting. Let's see what you're going for. Most of you would go for diffuse large B-cell lymphoma recurrent, central nervous system lymphoma, but many of you also would rather go and seek clarification. So we have a primary central nervous system lymphoma is not any option, but otherwise we have a bit of split of opinions. But diffuse large B-cell lymphoma seems to be one of the favorites here, but many of you also would see clarification. So when searching for the medical abbreviation DLBCL in order to see whether it's an ambiguous abbreviation, in the internet, one finds plenty of literature and they are all related to diffuse large B-cell lymphoma. Here a screenshot from the Leukemia Foundation website, and DLBCL is considered an aggressive type of non-Hodgkin's lymphoma. Now let us also clarify the medical background for the reported CNS involvement in the context of the DLBCL relapse. We have to distinguish primary and secondary CNS lymphoma. The diagnosis primary CNS lymphoma has been renamed based on the newest WHO classification and is now called central nervous system diffuse large B-cell lymphoma, meaning that the primary CNS lymphoma is characteristic for DLBCL. It is an extranodal aggressive lymphoma manifesting only in the brain, spinal cord, leptomeninges, or in the eye, and represents the vast majority of CNS lymphoma cases. Secondary CNS lymphoma represents a different condition. The term refers to a lymphoma that has spread into the CNL concurrently with a systemic disease, or to a CNS relapse, like in our case, during or after therapy, presenting with or without systemic lymphoma. It is most frequently observed in DLBCL, but it can also be seen in Burkitt lymphoma or mantle cell lymphoma, for instance. So in our case, a DLBCL relapse with CNS involvement is reported, not a relapse of a primary CNS lymphoma. If the verbatim would refer to a relapse of a primary CNS lymphoma, it would rather read DLBCL relapse of CNS lymphoma. So our verbatim is clearly referring to a secondary CNS lymphoma. Now let us also look at the staging of this lymphoma, whether this classification may consider the CNS involvement reported for our patient. So the first three stages that you see here only affect lymph node regions or only one extranodal site. But in stage 4 of the DLBCL, the tumor has spread to organs or tissues other than lymph nodes, such as the liver, lung, or bone marrow, meaning that in stage 4, DLBCL does not specifically spread to the CNS, but may also affect other organs. This stage 4 classification does not fully cover what has been reported in our case. Now let's again switch to the browser and look for the abbreviation DLBCL. No hit, so this abbreviation is not available in MedDRA. So we will have to look for the diffuse large B-cell. Let's see, I already find it. Diffuse large B-cell lymphoma. It's the first proposal here. Go to browser and let's look at this term in its hierarchy. So here we are. We have a separate HLT for diffuse large B-cell lymphomas. Here it is, the diffuse large B-cell lymphoma, and we see quasi-synonyms underneath this PT based on different classifications. We also, when looking at the neighbors of this PT here, we see PT diffuse large B-cell lymphoma recurrence. So this exactly represents what has been reported in our case. There is no term in there that would relate to CNS lymphomas, though. Refractory stage 1, 2, 3, 4. We saw the 4 classification. Yeah, it does not contain any information of CNS involvement. And that's it. So what we can say is that the diffuse large B-cell lymphoma recurrent, this would be the best option to represent at least part of what has been reported in our case. So now let me look for the central nervous system lymphoma. Here we are, central nervous system lymphoma. Go to browser. It's grouped under lymphomas unspecified, NEC, not elsewhere classified. And underneath we find the LLTs brain lymphoma, cerebral lymphoma, and primary central nervous system lymphoma. You saw that especially for the secondary DLBCL, it's a difficult abbreviation. At least for the primary, it's fully clear that it relates to that the primary central CNS lymphoma always relates to this lymphoma, to DLBCL. But the secondary CNS lymphoma may relate to other lymphomas as well. So that's why here the central nervous system lymphoma is grouped under lymphomas and unspecified NEC. So this would be the best option to really capture the full information in our verbatim. So primary central nervous system lymphoma would not be suitable because what is reported is not a primary CNS lymphoma, but a CNS involvement with the relapse of the diffuse large B-cell lymphoma. And no secondary term for the condition is available. So let us reassure ourselves, but there's nothing. So another option in the poll was metastatic lymphoma, but because we could consider the spread into the brain as a metastasis, but here is the non-Hodgkin's lymphoma metastatic. Go to browser. This would be too vague because our verbatim really provides the specific histology of the lymphoma. And the same holds true for this one and also the metastatic lymphoma. So what are the learning points here? At first, we had to make sure that the abbreviation provided in our verbatim is unambiguous. We then had to consult reliable references to better understand the disease and the reported scenario. And based on what we saw in the literature, we cannot subsume the CNS lymphoma under the PT representing DLBCL relapse, because a relapse or stage 4 of the disease may affect other organs and anatomical structures as well, meaning that we will have to split code to capture the full information. So with this, we propose to code to LLT diffuse large B-cell lymphoma recurrent same PT, and the neutral LLT central nervous system lymphoma. I would rather consider the second proposed LLT as a placeholder and submit a change request for a better term to capture the fact that the CNS lymphoma was not a primary one, but occurred with a relapse.
So, Caroline, that's the only question we've had. One of our attendees has asked you to clarify why you know that it's secondary. I know you explained this with your references, and then we have just had another question popped in to say, could you explain whether the fact you've used relapse and recurrent as synonyms, should these be treated differently? I think it depends on the scenario would be my take on that one, the use of the words relapse and recurrence, but I'll hand that over to you.
Yes, in oncology, relapse and recurrency is often used synonymously, and with CNS involvement really means it's the relapse manifests as a CNS involvement. So it's not that a primary CNS lymphoma has relapsed, but the relapse of the DLBCL manifests with CNS involvement. This is how I would, or we discussed it in length between ourselves. We would consider this a secondary, so a secondary CNS involvement.
Thank you. Okay, no other comments then. Let me have a look. One more. I personally would not choose the central nervous system lymphoma because CNS involvement does not imply that the lymphoma concerned the CNS. It could be a paraneoplastic phenomenon. Yeah, I guess that's there. Yes, I think so. I didn't think of that when we were looking at the examples, but it might be. Yeah.
But if you look into the literature, the relapse recurrency of the DLBCL often involves other organs as well, but also the CNS. So it's not really a paraneoplastic it's not referring to paraneoplastic symptoms, but really to a spread into the CNS.
Worst case, and it's worst case.
Worst case scenario is always the approach that you would take in pharmacovigilance, and in clinical studies you may have additional information to really classify this correctly. But if you have this information in pharmacovigilance, you would rather go worst case.
Okay.
So I hand over to you again, Jane.
Thank you. So here now we move on. I'll cover this one. I know we've had a request to cover the psychiatric terms today if we can. So I'll move on swiftly with this one. Had a problem with her insulin injection pen, and that affected her blood glucose level. So again, as always, what's being reported here? Is it 2 events or is there a combination term available? And then thinking about the problem with the pen, is it a quality issue that there's a problem with the pen? Or is it that there's some use issue which would make it a medication error? And that's something I'll show you in the browser, how the terms are placed in MedDRA. So overall, what would be the most appropriate LLT or LLTs here? So the first part, I've split the polling into 2. So let's deal first of all with had a problem with her insulin injection pen. What would we do with this one? Is it a drug delivery system malfunction? I'll let you read them. Then we'll talk about them. So this is just to capture the problem with the pen, because there isn't a combination term that could capture all of this. So we are going to split. Okay, so let's see where your votes are. You can carry on voting. So drug delivery system malfunction was the first one. Do we know that the problem, do we know that the the pen has malfunctions? That would be my question to you. For me, her saying she had a problem with it, was it that she couldn't use it? She found it difficult to use, and that's the second LLT I've given you. Was it that she found it difficult to use, or did it malfunction? Either of those two LLTs are possible, but we don't know. We don't have that much information to be able to select them. Then we have a device operational issue, which is very popular among you, I see today, or an operation use issue. So these two look like they're potential. Looking at them there, I wouldn't exactly know the difference between them. One of them is the device isn't operating correctly, and one of them is that there's an issue with using the device. So those two I see are popular. Incorrect dose administered by device. Well, it affected her blood glucose level, but do we know that is that an assumption that the pen gave the wrong dose? Nobody wants the omission, which fair enough. It's, oh, somebody's voted for it. It could be that the pen didn't give a dose at all. We don't know that. It's possible, but we haven't been told. And then we have that other term, unevaluable device issue, which again is very popular. So let's see where we go. That's the final voting. Those two are the winners there, device operational issue and unevaluable device issue. That's what you think. So let's go to the browser and have a look. I'll go to I always leave it here in case you need me to show you how to do it. There we go. So let's have a look at those device operation. I'll go hone in straight to those so as to see the difference between them. So we've got a device operational use issue and a device operational issue. Any others? No, these two would be too specific. So let's have a look at the hierarchy for these. We see that the device operational use issue goes under the PT of device use issue. And on the right-hand side, I can see that this is considered a medication error and issue. Remember, the word issues comes into that medication errors. So that's where we don't know what the problem is exactly and if an occurrence was intentional or not with the medication errors. Then we have the device operational issues, which is a device issue under the product issues. So again, we can see the difference here that these two, one of them means that there's a problem with the device, some kind of fault or malfunction, a quality issue, and the other one is a use issue, the word use here. So can we be specific in these, or do we need to select the one that you also was the unevaluable device issue, which is a more general, doesn't really tell us a great deal there. That one could mean a number of things. Unevaluable device issue, I can show you the hierarchy for that one. That one is in device issues again, as you'd expect, under the HLT of device issues not elsewhere classified. So that is an option if you feel unsure about using either of the others. Well, now we need to make a decision on which of those. Of the two, going back to our verbatim term, I'm not sure that we can assume that there was an issue with the device. She had a problem with the device, but she had the problem. It could be that it is a use issue. So of those two, I prefer this one, the device operation use issue, and I would feel comfortable in using that because we've been told there's a problem using the device, and I like that as a match. If you don't feel comfortable, you could use the unevaluable device issue, but I would feel comfortable with this one. So now we come to the poll for what about the effect on her blood glucose level? Is the blood glucose fluctuating? Is it abnormal, increased, decreased, or is it insulin hypoglycemia? So a few of you were choosing the fact that there was an incorrect dose administered. Very few of you just read it that the dose hadn't been given at all, but that you read that it was incorrect. My challenge to you would be that, do we know that any insulin was given? Do we know that the glucose level was high, low? Do we know either direction? And do we know that it was due to the pen? Could it have been that it was something to do with her? Maybe did she become stressed with it, or was it a problem with that, something else which may have caused it? So that we've got two main options selected there: blood glucose fluctuation. Fluctuation to me means that it's unstable. It's going up and back down to normal, or going down, going up or down and moving. Blood glucose abnormal seems like it's a safer option there. All we know is that there was an effect on her blood glucose. So let's close that poll. So our learning points is that I would evaluate the report and consider all the elements. And this comes to split coding again. Capture the device issue and the clinical consequences as closely as possible. Report as reported without assumptions. That's what we say. Don't assume the effect on the blood glucose. And try to distinguish between a device malfunction or a quality issue and a human issue or error, if you can. And some of you may argue that we can't be clear here, so that's why you preferred the unevaluable device issue. But for me, the operational use issue captured the fact that there was a problem. And if the device is critical to your work, if it's the device you're working on, or if it's relevant to the profile of your product, then you may wish to seek clarification. We're not saying you shouldn't or couldn't. Okay, any questions on that one, Caroline, or anything you'd like to add? No? No? I'm not hearing you, Caroline.
Yes, so we have a number of questions here. Why cannot we just use device issue? So the device, I think you have explained it, device issue is grouped under product issues. So it would indicate some kind of problem, quality issue of the device itself. Yeah.
Yes, I don't feel we can assume that, because it may be that she had a problem using it. It may be that she's new. We just don't know. So rather than make that assumption, I've opted for the use issue.
Manka would also rather prefer to just go to device use issue.
Mm-hmm.
And Faye is asking, how can you assume that the glucose levels were abnormal?
Well, we know that it was affected. We don't know it's abnormal, except that we've been told that her blood glucose was affected. So that to me shows that there's some abnormality there. That is a slight assumption, a bit like we do with some other lab test result coding you're reading the PTC. Worst case scenario, I would go abnormal.
Yeah. Same, I fully agree, because we have another comment in the same direction. Actually, blood glucose abnormal is not really correct, I think, because the effect on the blood glucose can also lead to a blood glucose value that is still normal.
Yes.
But here, I would also go worst case. If there's a problem with this insulin injection pen affecting her blood glucose level, why? Otherwise, it would just have been reported as a problem with the insulin injection pen, and the glucose level would not have been reported at all or mentioned at all. So I would also go for abnormal. But
maybe that's
there's still controversial discussions about classification as either use issue by the patient or quality issue of the pen.
Yeah. We can't be sure. We could spend the next half an hour discussing it and we probably still wouldn't know. And that may be why some of our group in the poll preferred the unevaluable issue. And that is the option as well. I went for the operational use, but you could equally say we can't be clear. Therefore, we would go for the unevaluable device issue. And I can we can see where that one is here. It's also within the product issues. So you could have chosen device issue, or you could have chosen unevaluable device issue. I opted for the fact it was worded that she had a problem with it. She had a problem with it. Made me think that it's a use issue.
Yeah,
She had a problem
we
with
both
it,
agreed on
be a
it.
device
Yeah.
issue. Yeah.
And we have a comment from Martin as well, saying that in his organization, they quote all unqualified test results that are reported as with the respective abnormal LLT. Yeah. So confirming what we have chosen to.
I've seen that guideline as well when I was in the industry. Yes. Okay, so can we move on in the interest of time? I hear what you're saying, and I agree with you. It is difficult. We go to one side or other, and that's the way I've chosen to do it. We've got just under 30 minutes, so let's try and get the next 3 done. So for the past 2 years, the patient had been hearing the voice of his mother blaming him for her death. This is a very unpleasant report. What is being reported here? Which sock would you expect it to be in? So the patient's hearing voice, and is there a diagnosis that can be assigned for this? Is there an LLT that reflects this exact scenario? Well, my first thought, so that I know where to go in the browser, is I could say, well, which sock is it in? I probably would be thinking of the psychiatric sock, but then I need to know a bit more specifically where to search within that sock. Is it an abnormal thinking, hearing voices? Unlikely. It is hearing voices. We've been told that, so we could search for that within Medra if it was in there. Is it an hallucination? Is it a delusion? Or is it an illusion? Now, as you'll see in the browser, these are concepts which are grouped together within the HLGT, and we'll have a look at that shortly. But what's the difference between them? So let's look at the Dorland's definition. You'll know we always go to Dorland's first. Hallucination is a sense perception without a source in the external world, a perception of an external stimulus object in the absence of such an object. So it's seeing or hearing or tasting things which are not really there. Delusion is more of a belief. It's a belief that's firmly maintained in spite of incontrovertible and obvious proof of or evidence to the contrary. So this is a fixed irrational belief, is what sometimes I've learned the definition before. It's a belief thing rather than an experience or a perception. Illusion was another one. This is a false or misinterpreted sensory impression, a false interpretation of a real sensory image. So unlike hallucination, where there was nothing there in reality, Dorland's is telling us the illusion is some kind of distortion or a false interpretation of a real sensory image. So that's what I take from the dictionary definitions on that. And we may have some experts online today. So if you have any comments, please put them in and we'll hear your thoughts on it. I confess I'm not an expert on this. Occasionally psychiatric related terms do get reported, and it's something we've been asked to cover in these sessions. I found an article online from the Handbook of Clinical Neurology, which looks at the difference between illusions, hallucinations, and visual snow. And 2 sections of this article were worth looking at. One talks about perception, and that perception is the way sensory information is interpreted and experienced by the nervous system, largely derived from information in the outside world, such as vision or hearing, it could be, not always accurate. Sometimes the sensory processing could be distorted, where we see here, or deception, and a distortion or a deception. So we talk here about illusions, again from the same article, illusions and hallucination, and they reinforce what we read in Dorland's. Both of these are disorders of perception, the most popular concept being that illusions are a perceptual distortion of something that is really there, while hallucinations are generated internally by the brain itself without reference to reality. So that's, although it can vary in clinical practice. So that's what we saw. So now these are the concepts. Which concept would you go for? So these are not necessarily MEDRA LLTs. These are the concept. What concept would you be looking for in the browser? Yeah, let's see where your votes are. Oh, look at that. Overwhelmingly, we seem to be all agreeing that it's some kind of hallucination. So let's go to the browser and see the placement of these terms. So I'm going to go to the psychiatric SOC because that's where I think they will be. Under psychiatric disorders, we have thinking, where's the one I'm looking for? Disturbances in thinking and perception is the HLGT. So this is the word perception, links with what I've seen in the definitions. And I would come here as I break it as I go. It helps me to navigate. The HLTs are very helpfully labeled. We've got delusions, hallucinations, thinking disturbances, and perception disturbances. So we felt it was hallucination. So I can open that. We call this top-down searching. And here we see the types of hallucination. We've got the different senses specified at the PT level. We know that he was hearing voices, which would be an auditory hallucination, and this would be the any of these LLTs under here, verbal or auditory. I could look for hearing voices just to be sure. We always say search in the browser with the exact words as your first step. There isn't anything in there, just to show you. I did that before we started. I'd be looking for one of those auditory hallucination terms. The learning points is to distinguish between the differences between perception and thinking. This is a perception disorder and it's not grounded in reality. His mother's voice isn't there. So we'll distinguish between illusion and hallucination or delusion. Be clear whether it's a sensory distortion or deception. So that's, again, is it real? Is there a real stimulus or not? So those are our learning points, and I'd choose hallucination auditory or one of the other LLTs there. Any comments on this one, Carol Ann?
We had the comment that maybe LLT feeling guilty would also be suitable, but I think it's this one is much too vague.
You know, that occurred to me when I was preparing for this. I was thinking about that. Would we code feeling guilty? Is it part of it? It hasn't specifically been reported. So we don't exactly know. We don't know. Is he feeling guilty? He may not be. It's possible. I agree with you. It crossed my mind as well, but I wouldn't select it because it hasn't been reported. I would just go with what we know is that he's hearing voices and, yeah.
Okay. And would you also code death of mother was one of the questions. Well, this would rather be, yeah,
we don't
family
know
history term, so to say.
Yeah. Social circumstance. Yeah. It's possible. We don't know when she died. We don't know that. We don't know how. It may have been that she died a long, long time ago. But yes, we do know she's no longer here. Okay, let's do the next one because there's some other things. This is a similar one. After taking, I say similar, but you'll see when we do it. After taking drug X, when he looked down, he saw both his legs growing more and more until they seemed to be 5 meters long. So again, do we need to know what type of drug it is? Well, it may be some kind of hallucinogenic. That might be something you know if you're dealing with the case. It may be that the context here is quite important for you, or you may know more. But again, we ask the same question: what is it the patient is seeing, and is this grounded in reality? Is it real? He's looking at his legs. Well, his legs are definitely there. So there is some kind of distortion rather than a deception in this case. Is there a name for this phenomenon, and what would we code it to? Those are my questions when I first see it. I've given you a selection of LLTs here to choose from. As I say, we're not experts on this. It is a specialist area. But what would you say? So I've given you a few. Visual hallucination or optical illusion. Is it irrational? Is it a somatic hallucination? Well, soma is the body, isn't it? Something related to the body. A somatic hallucination or a somatic delusion. Does he see his legs being long, or does he believe his legs are long, or that there's something wrong with the body? Where do those two terms fit into this discussion? Let's see where your votes lie. Visual hallucination seems to be, but also optical illusion is quite commonly selected there. And we'll give you our thoughts on this shortly. Everyone had chance to vote? So a somatic delusion, so remember, a delusion is a fixed irrational belief, some kind of belief in the evidence when there is evidence to the contrary. A delusion that there is some alteration in a bodily function or organ, and one of the subtypes of a delusional disorder. So this I would see as being more, somebody believes that there is something wrong with them, wrong with their body or a particular organ, even though they may be getting test results that there's nothing wrong. So the evidence is coming in that there's nothing wrong, but they believe it is. So that's the concept of a delusion. It's a belief rather than seeing something. A somatic hallucination is perception of a physical experience. So this is feeling unwell. People who say, I just don't feel well, and yet again, test results are coming back that it's fine. So it's some kind of hallucination that they don't feel well, but there's nothing wrong with them. They're feeling something. So again, not really to do with the vision that there's something wrong. And also the fact that his legs exist, it's grounded, there is a real stimulus there. He has legs, but he's seeing his legs distorted. So let's go back to where we were under the psychiatric disorders. And for me, based on what we've seen in our definitions, I would say that it's a distortion. So I would go for more of an illusion term rather than a hallucination. And so here we saw our visual hallucinations were here. Now we've got perception disturbances, not elsewhere classified, under this HLT. And here is where we have the PT illusion. We don't have separate illusion terms for all of the senses as we do for hallucinations. We only have one PT of illusion. And there we have the optical illusion, which would indicate that it's a visual or if you're not comfortable with that, you can do a perceptual distortion, perceptual disturbance for all the others. They're all seen as synonyms with the term illusion. Right. The other terms here, autoscopy, nobody came up. This one was one I did think about including. This is where you have an out-of-body experience. Auto, yourself, scopy, seeing yourself. So it's where you perceive that almost there's two of you, one of you looking at the other one of you. And there's the somatic hallucination term there, where somebody thinks there's something wrong with them. So oh, let me go back to the slides. I haven't given you the answer yet. I'm a bit afraid of the controversy on this one. So just consider what type of problem is reported, browse Medra fully to assess all the options, and consult references as you saw us do. And you can see the rationale if you find terms in Medra that you're not sure what do they mean. As we all know, Medra terms don't have definitions, but it can be useful to see the rationale that was given by our medical team when the term was added. Our international medical officers will write a short rationale for why a term was included, and I find that is sometimes helpful. Any comments on this one, Carol Ann? Optical illusion is what I would go for, based on the rationale that his legs are really there, but he's seeing a distortion.
There are no specific question. One is there were two comments, and that's why I would like to address it, about drug-induced hallucination, so drug-induced hallucinosis. So you explained that this is an illusion, not an hallucination, because the legs are there, of course, but they are perceived as different as usual by the patient. And now about the drug-induced, what we have in the verbatim is just after taking drug X, it's a timely relationship. We are not told that this is due to drug X. And I would always make this difference. So if we had an LRT that would read drug-induced illusion, for instance, we would not choose it because it's not made clear by the verbatim that this really has a causal relationship to the drug. It's just a timely relationship. That was the only comment.
Thank you, Carol Ann. Great. Well, I'll hand over to you then for the next term, because we wanted to do these three in a block. So let's do the next one if you can now. Thank
you.
Yes,
here I am. So let's continue. And here we have another term that looks strange at first sight, tasting music. So do we need clarification? Is this a misspelling or incorrect wording? Or is this a valid, recognized medical concept? And is there a name for it? So how would you approach this verbatim now? How would you code tasting music? Taste disturbance, phantom taste perception, sensory processing disorder, synesthesia, hallucination gustatory, or hallucination auditory, or would you seek clarification from the reporter? What would you do? Because you would seek clarification because you think that this is an incomplete report, something has been missed here and needs clarification. So let's see what you're going for. Many of you have voted already. So most of you would seek clarification from the reporter, would assume that this verbatim is somehow incomplete, not really clearly describing a medical concept. Others would go for synesthesia. But again, everything is selected here also. Hallucination terms, sensory processing disorder. So let me close the poll. It's a difficult verbatim again. We always use verbatims descriptions that are real, so they're not invented. So let's switch to the browser again and look for our terms. Taste disturbance, of course, is there. Very general term. Here we are, and it's grouped here under SOC nervous system disorders and has a secondary link to gastrointestinal disorders. But it's not suitable because our patient should not experience any taste sensation. He or she is not eating or drinking something, but just hearing music and then taste something. Sensory processing disorder. Let's look at this one. Here we are. Again, primary shock nervous system disorder, cortical dysfunction. So it's much too vague. It does not describe what was reported here, that the patient heard music or was hearing music, and then when hearing music has always these taste sensation. Phantom taste perception was another option, and this is now grouped under, oh, I don't know how to pronounce this, dysgeusia, and here we are, sensory abnormalities related to the taste. But this would not, this refers to a situation where a patient experiences a taste sensation in the absence of any actual taste stimulus. This is actually what is reported, but this term would not capture the fact that the patient tastes music. It would not capture that this phantom sensation is accompanying a real auditory perception. And this, the next one, hallucination gustatory. Here, under hallucinations, has the same problem. This would not cover the fact that the taste hallucination is triggered by an auditory stimulus, the music. Same holds true for hallucination auditory. It's even completely wrong. Here, let me show you where to, it's of course also under, here we are, under hallucinations, here under psychiatric disorders. So hallucination auditory. So this would be completely wrong, because our patient is definitely hearing music, perceives a real auditory stimulus. So this would be wrong. Now, what about synesthesia? This was the other option. Quite an unusual term, some infrequently used or infrequently reported. Go to browser. Let's look where we find it and whether there are LLTs underneath that would better explain what is meant by that. But here, synesthesia is just the term in British and American spelling, and it's grouped under paresthesias and dysesthesias in shock nervous system disorders. So, but because there is no LLT available that provides a more colloquial wording, we will have to reassure ourselves whether this LLT is really suitable for the reported condition. And if it is not, we will have to seek clarification for our verbatim. Now let's see. Here is a description of what the term synesthesia means. Synesthesia is a neurological condition in which stimulation of one sensory or cognitive pathway, for example, hearing, leads to automatic involuntary experiences in a second sensory or cognitive pathway, such as vision, or in our instance, taste. Simply put, when one sense is activated, another unrelated sense is activated at the same time. This may, for instance, take the form of hearing music and simultaneously sensing the sound as swells or patterns of color. So here this would be visual hallucinations. So when looking at such verbatims, try to understand the information through abstraction. Normally you cannot taste music, but here a person perceives an undefined taste when listening to music. And put this information also in a medical context covering the full content. So we have a real auditory perception and a taste hallucination. So we have to cover this full content. We search the terminology for potentially suitable terms in the area of hearing and taste disorders. And this is what you would usually do with bottom-up and top-down searches. And you should also consult reliable medical references to understand unfamiliar, rarely used medical terms in MEDRA. So if you find a term like synesthesia in a group of terms that may relate to the verbatim that you try to code, then really look for medical definitions for these terms, because especially in the psychiatric disorders, you find many medical terms derived from Latin that have no further LLT in more colloquial language that would really explain what is meant by that. Here you would always have to look into medical reference, reliable medical reference, in order to understand what is meant. So we would code this verbatim to LLT and PT synesthesia, because you saw the definition of synesthesia. It's exactly reflecting what has been reported in our case. And we would consider the taste hallucination in this patient as a specific symptom of the synesthesia. And based on the PTC guidance, if you have confirmed diagnosis, here the synesthesia and characteristic signs and symptoms, so the hallucination of a different sense here, then it's sufficient to code the diagnosis only. Any questions, Jane?
We've had a couple of interesting comments. We've had one of our attendees is suggesting that it could even be a change request for a more specific term, lexical gustatory synesthesia. So showing that it's the taste and the words, or
Yes.
music, words, music. And also, Yelena tells us that there's a book, I think it's a book, Yelena, Speak Memory by Vladimir Nabokov, describes the taste of letters. So I was saying to Caroline, I've come across it in books. I think there is, if you're interested in this area, there are books out there. I know Oliver Sacks, I think, has done some as well on it, describing it.
This would, of course, be an option to request a more specific term, but I'm sure that it would be grouped under PT synesthesia. So it would be helpful to have them, so you would then capture this information more specifically, but still the medical concept behind is the synesthesia.
And then we've had a contrary comment from Martin, which is protecting the stability of MEDRA. That is saying if we add that one, we'll have to have all the other combinations of seeing colours and seeing and there's so many combinations and permutations. MEDRA we'd have a lot of LLTs added, and we do try to keep MEDRA as stable as possible and avoid overpopulation. So sometimes I comment that our medical.
I fully agree, Martin. I fully agree. But it's difficult to keep the balance there.
It is. That's a whole topic for another webinar, another day. Keeping the balance between what should be added and not, to keep the balance of MEDRA. So I think, Caroline, we're running short of time. There was one question which about if I take the screen back from you, I think we're going to have. I am sorry, those of you that have prepared. We will have to carry over the other remaining three for next time. We had a question of a term that popped up in the browser. What is a pseudo hallucination? So just to answer that one, I've brought it up here in Dorland's. A pseudo hallucination is and according to Dorland's, an image perceived to be occurring externally, but the subject knows is generated in the mind. This is where there's enough insight that the patient knows what they're seeing is unreal. They know they're seeing things, but that's not really there. So this is a pseudo hallucination, according to Dorland's. So just as to wrap up on that one and that question. Right.
Thank you, Jane.
Okay. Anything else you want to add, Caroline, on any of those?
No,
No?
nothing.
Just a
I hope
reminder.
that
No, nothing to add?
no.
Just a reminder that we've been doing these sessions now for probably around 3 years. And so I think it is 3 years in November. So there are a lot of recordings. The terms each time are different. We have some US colleagues who also do them, which have different terms as well. They're all recorded on and are available on the YouTube channel. Bear in mind that Medra has changed slightly over time, so just that's the caveat. And there's also an index on our website where you can look at what terms were covered. The terms are listed in the YouTube, but there's also an index that you can search if you're interested in psychiatric terms or particular types of terms. So that can be helpful. It can pinpoint you to the recording that you want. So that's that thing. And then the other thing is, some of you have already found it. We do have an instant survey that we share here. This is so that you can put your thoughts straight away. And this is where you can tell us what topics or what verbatims you'd like us to cover in the future. I know that we always run short of time. We're always overambitious. I do apologize for that. We just enjoy doing them and we get overambitious. So we really do enjoy these sessions and love hearing from you and your thoughts. So put your comments in this survey right away on your phone in the poll everywhere if you've still got that open. You will also receive a survey after the session. So if you want, you can put your comments in there as well, either or. We will see it all. We do appreciate your comments. It helps us to change the sessions based on what we hear from you. We often hear that we'd like the session to be longer, and that's something that we have considered, but we feel that an hour and a half is long enough at this level of intensity for you to concentrate and for us to present. So that's why we're keeping it at an hour and a half. So that's the surveys. The last thing, I also, just in case you joined us late, if you're only eligible for a certificate if you're here for the whole session with a few minutes allowance if we overrun and you need to leave. But it takes 2 days for the certificate to be processed, and in 2 days' time you'll be able to download it from our website using the self-service application, top right-hand side of the screen, SSA, self-service application, training, retrieve certificates. You enter your email address and you will get your you'll get a validation email, and then you'll be able to retrieve your certificate. Okay, so 2 days, remember, so don't try before Friday. Otherwise, apologies, we're a little bit over time, but thank you, Carol-Ann, for your collaboration today.
Thank you, Jane, for you. And we should mention that in the survey, you can also make proposals of new verbatims that you came across. Of course, they need to be of interest for in a more general way, not too specific, but if you have interesting verbatims, we are always interested to see them, and we can definitely then include them in one of our next sessions.
Yeah, we really do try as much as we can. We do try. So it's lovely to see you all again. If you've got comments for us, feel free to email us. Here are some WhatsApp groups you can scan and join with your phone if you want to keep up to date with our news, or contact us that way. Otherwise, it's very nice to see you all again, and we look forward to welcoming you back for one more before the end of this year.
Yes. So
okay.
Bye-bye, everyone.
Bye-bye, everyone.
Take care. Bye-bye.
Bye-bye. Bye-bye.